Welcome to Future Sense Now, where we explore the landscape and byways of our shared futures, an e-zine of the Futures Forum Live online. We exchange ideas, information, and inspiration about the futures we want. Get Future Sense Now with host Dr. Claire Nelson, futurist and editor of Human Futures.
We have maybe about 10 people in the room, and we're going to open the lines after we've done our first round of questions. And we are recording, so just want to say, let's get ready to start. It's midday, let's get ready to start. Thank you so much, everybody, for joining us. Greetings and welcome to Future Sense Now. We're doing our first live roundtable dialogue. In the past, we have done individual podcast conversations, and our four of the people who are special guests, and there were not two special guests, will eventually have in-depth interviews online. In fact, four of them already posted online. We intend to have the other one posted later by tomorrow. So we are in World Health Day, it's April 7th, and as you know, we're all finding ourselves amidst this global crisis. And so I've assembled this group of leaders and change makers and entrepreneurs to help us have this conversation on healthcare futures 2030 beyond COVID, right? We know we're dealing with COVID or whatever, who knows what it is. Some people are calling it other things, but we are certainly dealing with a crisis. And so we want to do this focus on the future in spite of where we find ourselves today. And in fact, our guiding question for today is going to be, how might we leverage the opportunities in this crisis to move forward on a journey towards SDG 3, which is health for all in Africa? We know already what some of the challenges are. And SDG 3 asks for us to look at ensuring healthy lives and promoting well-being for all ages. For me, that goes beyond looking at gross national product, but actually moving towards gross national well-being as a metric of choice for a smart future. And the aims of that are better care, improve overall quality, making healthcare more patient-centered, reliable, accessible, safe. And accessible, we're going to build into this for Africa, obviously affordable, right? So accessibility doesn't mean you have it, but you also can we afford it. And of course, we then have to take into account economic and social inequalities, of course, big distances, climate, environment, and all those things. So we are going to borrow from our past and our current, but we're going to jump into the future. And we're going to be joining today by Mark Millwood. He'll help me host this session. Mark is executive producer and host of the Jamaica Diaspora Show. He also happens to be an engineer who has done some work around issues of healthcare, in particular using Lean Six Sigma to improve healthcare service operations. So Mark will serve as co-host of our roundtable. In our panelist chair, we have on the camera right now, we have Yaya Mbawa. He is the CEO of Mbawa Group and also the founder of a telehealth company, Zense, which operates in many countries in Africa, in West Africa, I think 8 countries in West Africa. We're also joined by Dr. Genghis Mordenis. He's a associate professor of anesthesiology and pain medicine. But more importantly for our conversation, he's been doing some work and writing around the issue of traditional / alternative / complementary medicine, as he has told me, in Africa and other developing countries. We're also joined by Dr. Chasey Voma, who is a clinical pathologist with a long set of 4-syllable, 6-syllable words in her dissertation. And she'll be talking about Labs to Doctor Express, her startup, which is trying to bring labs not only to disadvantaged groups here in America, but also to how to reach people in Africa and make it more affordable. Labs and lab tests. And finally, right now on camera, we also have Jyoti Tadesi, who is a co-founder of Diaspora Care, which is in the business of trying to provide money to help us pay for this. So we're going to turn the conversation over to Mark at this moment and see if we can get started on this conversation. Mark, over to you. So before a little bit housekeeping rules, everyone please make sure your mics are on mute until you're ready to ask a question. Secondly, also, we're going to be doing this in basically 3 rounds of questions before we open. So round 1, we will ask the panelists to talk about their vision and their challenges, revision. Round 2, we'll talk about challenges. Round 3, we go into the financing piece. Then we do a round where they can ask each other questions. And then we finally open the floor to general questions. Because I'm sure they're probably hearing things from each other they want to ask each other about. So without further ado, I'm not seeing Mark. I guess I lost him. So I will probably go ahead and get started. So in our first question, to get started, we want to talk to Dr. Chenjis, Dr. Voma, and Yaya. What is, we know that we're talking about SDG 3, but it fits into a larger context, obviously. From ending poverty to hunger to gender equality to climate to energy to water and sanitation. In fact, you really can't have health unless you have these other things, right? So there are bold, ambitious goals, and it would seem as if we're in a moment of setback. But my question in asking this guiding question is it really the case that this crisis doesn't provide an opportunity? And if so, how can we leverage the opportunities in this crisis to move forward? So my question to each of you, and let's begin with Yaya. Given all we know now about health tech and fintech and engineering tech, how might your work, and in particular your company, help us move towards SDG 3 and health for all? You have 2 minutes.
Great. Well, thank you, Dr. Nelson, and good morning, good afternoon to all of the panelists. I'm really privileged to be amongst all of you, and so really happy to be here to share my thoughts. So, Dr. Nelson, to your question, I think that this pandemic, although it's really a dramatic situation around the world, really brings an opportunity for the entire world to really understand that, we always say we have a connected world, that we have a global village. I think literally in the context of healthcare, we have now the opportunity to really see how connected our worlds are, specifically the healthcare systems. And we really are, I'm going to actually quote what I've heard just recently, we are just as strong as the weakest link. So in that sense, it's really important for people to now understand that it's, we need to make sure that all the healthcare systems or infrastructures around the world have to be strong enough to, one, provide access to basic medical care to people, but also be able to sustain such massive pandemics, right? I think in terms of opportunity, I'm going to speak now in the context of Africa, which is where I am right now. Mm-hmm. There is an opportunity for Africa to really leapfrog into future technologies, right? So we know that according to the World Health Organization, Africa faces the world's most dramatic public health crisis. High rates of communicable diseases, rising chronic diseases, and so on. So the burden of disease is really, really high, significant. Yet we have a shortage of physicians, right? So we're not going to train physicians overnight. That's not going to happen. But I think we have an opportunity to use technology to really create that bridge and mend that gap and leapfrog into future technologies. So we're talking about telemedicine today. I think everywhere around the world, starting with the US, everyone is actually looking at telemedicine or telehealth as a solution to provide more access to quality care to people. And I think now is time for Africa to really leverage technology to catch up and even define the standards for future technologies in telehealth or artificial intelligence, whatever it is. So I think that's what I see as an opportunity that this current crisis creates for not just the world, but also for Africa.
I'm sorry, I was disconnected briefly. I'm back with you now. Thank you for that.
Yeah, so can we go to Dr. Voma to answer the same question? Given what we know about health tech, fintech, engineering, how might your vision for labs to doctor express help with the SDG 3 and health for all? We're not hearing you, Dr. Voma.
I was muted.
Yeah.
Knowing that SDG stands for Sustainable Development Goals, the plan for Lab to Doctors Express, based on what we are experiencing currently on the pandemic, is to be able to make available the proper testing devices that would facilitate testing. And in a situation like this where the real process is a very contagious virus, not just making the testing process available, but also being able to meet people in the convenience of their location to be able to provide these testing services to them. That way, we also observe social distancing as well as being able to locate those who are infected in the community and give them the treatment they deserve. So this would actually mean bringing a lot of technology, a lot of testing devices into countries like Africa, where the laboratory testing system is really not developed, to be able to get the people in the rural areas to equally have the opportunity to have themselves diagnosed when they are sick, just like the people in the urban areas. So this actually means that through the Lab to Doctors Express platform, we are going to be able to design testing platforms, different devices that will be able to detect and test through affordable means at cheaper rates, to be able to test those diseases that are affluent in those areas in Africa that delay progress or cause a lot of diseases. For example, malaria. If we could get testing devices that could be able to, that could be distributed right up to the rural areas, I think this would be able to facilitate treatment and diagnosis. Even in the case of the pandemic we are looking at, currently not every city has access to testing, not even in the developed countries. Not every city has access to testing. Even when they have access to testing, they don't have access to the right test methodology. So the goal of Lab to Doctor Express, once again, is to be able to meet the community where they are in the convenience of their location and provide the testing services that are needed to treat and make the community healthy again.
Thank you. Professor Martinez, what are you saying in terms of complementary medicine? How might we look at complementary medicine now in a crisis, but use that also to leapfrog and move our agenda for SDG 3?
Well, the modern medicine or conventional medicine, especially after the Second World War, was very successful for antibiotics and medicines. So the medicine stayed in the hands of the pharmaceutical companies and medical equipment companies. And they, in a way, ignored the traditional methods. And they said it's an alternative method. But after so many years, where we are now, actually the crisis in health sector was before this pandemic. What happened? There was the difficulty to access to the medical services. The cost was becoming very high because of the technology or physician. And then the satisfaction because of the side effects of the medicines, or without taking the psychological side of the patients, even for just simple headache, there wasn't complete success. So in this case, this pandemic broke down all those discriminations, and the traditional and alternative medicine was in a way considered by the World Health Organization as traditional and complementary medicine. just to complement the modern medicine. And now it's even one step further is integrative medicine. So the health is not anymore as disease focused, it's human being focused. And as a biopsychosocial being, the human being is not considered anymore just a virtual identity who is getting drug dependent even for lifelong. Instead, we should need personalized and holistic approach. So in this way, traditional methods are becoming again popular. And after this pandemic, I believe that there won't be any more this discrimination to get into the health services, and traditional medicines will be standardized, scientific and evidence-based acceptance and integrated into the modern medicine.
Thank you.
Let me add that I've got disconnected as we just started, but I'm back. So now we're on time and we are going to go into round two. And in round two, we want to give each one of you an opportunity to discuss the challenges, weaknesses, threats that you foresee that you now face or will face in the next 2 years to move forward. And later on, we'll discuss finance. We'll identify that point in time. But so we can start with, I'm not going to be good with the names. So can I use the first name, Yaya, to discuss the challenges, weakness, threats, and that you foresee over the next 2 years as we go forward?
Okay, well, Mark, I think you pronounced my name perfectly. And
okay.
So I think that in terms of, threat or challenge, right now, I think the focus is very much on the pandemic, the COVID-19 pandemic. And everyone is actually investing into finding a solution to sort of, address that issue. And, I think there's a bigger conversation that needs to be had about, well, there are other pathologies, other diseases that are really, dramatic as well. And, I think my concern with what's happening right now is that, there might be some neglect in the existing pathologies. We have issues with malaria and the whole host of things still ongoing. There's also talk about telehealth. Everyone's talking about it. And it's, obviously it's the perfect solution to provide access to care to patients, right in confinement, as we told doctors. In Africa, for example, doctors are actually shying away from going to the hospital because they're concerned about getting infected, and that's the real, that's reality. So telehealth definitely is a solution, but I think that we need to make sure that we don't look at telehealth as a silo. So it has to be sort of part of an overall digital health strategy for each country. So I think as we're looking at solving immediate problems caused by this pandemic, we have to look at it in the perspective of how do we really put that into the context of redefining or sort of restructuring the healthcare systems. Because at the end of this pandemic, if we haven't really thought through how to really craft that, we might actually have the same problems to deal with going forward. So that's the threat that I see. But for me, as a health evangelist, I'm obviously in heaven because now people really pay attention to what we say about telemedicine and how we can help provide better access to quality care. So that's what I can say about that.
Yeah. Mark, your voice is gone, so I'm not hearing you. Okay, so Mark, I'm not hearing you.
How about now?
Yeah, go ahead,
Okay.
please.
All right. So, is it Genghis?
Genghis, yes.
How do you say it? Okay.
Genghis. like
genius. Okay, so the same question, you know, with regards to the challenges, weaknesses, and threats that you foresee and you expect to face in the next 2 years to move forward.
Nice. So in the health sector, the definition of health is changing. It's going more to wellness, well-being. It's not just to treat the disease, but is a wellness and try to prevent the disease, infectious disease or others, and then eradicate the infectious pathogens. So as the previous speaker said, with telemedicine and with the technology, the high standard health service could be reached easily with less costs at any case. Instead of going just to the hospital when you are sick, the data collecting, analyzing will be better done with new technologies. So there will be better monitoring, a high quality standard approach with the new technology, non-invasive diagnostic and therapeutical methods will be more introduced, taken together also traditional remedies, herbs or homeopathic remedies, etc. And it will be more putting the human being at the focus, not the sick person and disease oriented, but human being as a biopsychosocial being, and try to make him or her in a good shape, wellness. So this requires, the well-being requires better infrastructure. So the health will not be restricted just with a hospital, doctor, or insurance company, but it will be in a larger stage, as in the SDG 3, lifestyle will be essential. And in the wellness of the lifestyle, what's essential is the food, I mean, natural life, good produced food, exercise, regular exercise, and stress, psychological support. And for this one, there is the need of security of the government. And in this pandemic, we have lived that people did not feel this security from the government or from the health sector. So this should be re-established to give the security to the people that whenever something happens, they will be well protected. And that's why there will be better monitoring and early diagnosis and early intervention. So it won't be anymore just disease oriented.
I have one follow-up question.
No follow-up questions. We're going to lose our thing. I have to come back to that afterwards.
Right.
Let's go straight to Dr. Vollmer.
Okay. All right. So, okay. Dr. Vollmer. Oh, Dr. Vollmer, unmute your phone. Unmute.
I just did that. Thank you.
Okay. All right.
So thanks for the opportunity again. So the question was, what are the challenges, weaknesses, and threats I see going forward to be able to attain the sustainable development goals?
No, specify it. To attain your goal. We're focusing on your project, because at the end of the day, we're trying to figure out how are we going to move. Each of us here on this table have an agenda. You're working on labs, Yaya is working on telehealth, Dr. Martinez is working on how to make complementary medicine standardized so that people in Africa who are used to using bush teas can use them and know exactly what they're using them for. So what are the current, in the next 2 years moving forward, what are the weaknesses and threats that might impede you from moving forward? Not financial, we'll come back to finance after.
So some of the challenges, weaknesses, and threats, when it comes to Africa, top on my list is bad governance and embezzlement. So even when you get companies, if you get contributors, if you get people who want to fund your project in Africa, by the time it gets to Africa, it's in somebody's pocket. What I know so far about Africa is if you want to help Africa, instead of giving them the money, you give them what you want them to use. You give them the tool. So in the place of, so under my Lab to Doctors Express, the goal is actually to be able to provide medical testing devices, handheld medical testing devices. So another limitation would be, I would like to have people on the ground. I would like to have researchers that I can collaborate with in Africa to be able to get these projects going so that they can actually use the infectious agents in Africa for us to be able to come up with genetic targets and develop these devices that I'm looking at. So another goal would be able to get people to sponsor the projects from the US. That way we can be able to see how it works in the US and be able to extend it to Africa. So sponsorship, bad governance, embezzlement in Africa, and being able to have collaborators in Africa that will be able to collaborate with me from the US. Thank you.
Okay. Well, thank you very much for that. Well, I'm going to hold my follow-up question for Jyoti. Is going to talk about how his company can address financing, healthcare challenges. So please address what you're working on now and how it's working and what's planned next. I did attempt to go on diasporacare.com, but wasn't successful in watching that video. So could you please, Yote, talk to us with regards to that?
Absolutely. So good morning, good afternoon, good evening, depending on where you are. Very much pleased to be part of this panel. My name is Jote Tadessa, born and raised in East Africa by way of Ethiopia and Kenya, currently living in Minnesota. So the project initiative that I'm currently working on, called Diaspora Care, is really an initiative that is conceived on the thought of how do we create better healthcare inclusion through innovative financing. The driving a positive outcome, a quality outcome when it comes to healthcare delivery is, whether we like it or not, is dependent on our ability to finance it or not. I will give you a scenario. The average healthcare expense per person here in the US is estimated to be about $10,000 per year. Now, you take the same calculation and you apply it in a country like, let's say, Ghana. The average healthcare expense per person per year is less than $100. Now, take that number and apply it to two people living in the US versus in Ghana who are diabetic, right? Chronic disease patients. Now, when it comes to treating a chronic disease patient, all the way from diagnosis to getting better in becoming productive members of society, the needs of these two patients in two different continents are the same. They want to feel better and become productive members of society. However, their journey of getting well is completely, drastically different. Because treating a chronic disease, $98 per year for somebody in Ghana, that's a non-starter. So we felt that we need to create an ecosystem that provides the ability to aggregate funds in order to deliver not only quality, but affordable healthcare services. That's one of the missions of Diaspora Care. Where do we start that? Well, we looked at the African diasporans who remit over $50 billion back to sub-Saharan Africa every year, which about 20 to 30% of that is estimated to be towards healthcare expenses. I will give you an example where if my aunt today calls me from back home and says, son, you know, I've just been told that I have diabetes and I need financial help to pay for my medication. Well, yes, I will send that money, But even if that medication will cost $20, culturally, I don't send the $20 10,000 miles away. More than likely, what I do is I send $200, $300, $500, thinking that it would last my aunt for a longer period of time to get her medication. But I do that without having any idea about her financial reality on the ground. She may receive that money, and the first thing she may do is repay the loans that she'd been taking from her neighbors and friends, right? So Diaspora Care has created a platform that enables for a person like my aunt to walk into her local pharmacy, indicating that she has a sponsor, a payer who can pay for her medication, and walk out of that pharmacy, where the platform actually takes care of the payment and the disbursement of the fund to the pharmacist as a local service provider, right? That's kind of the core foundational tenet of what we're doing. But we also know that pharmacy is just one of the puzzles of amongst the overall healthcare ecosystem. There are the doctors, there are the clinicians in the clinics as well. And we are currently have deployed the platform and currently piloting in 2 countries, primarily Ghana and Kenya, and we are learning a lot. We have both individual and chain pharmacies who are participating in the platform currently. But I can share further in terms of what we're planning to do over the coming years. But I think the one of the biggest barriers right now is because the financing process is so disorganized and disconnected. We are creating a platform ecosystem that actually brings payers, healthcare service providers, and the receivers in such a way that we provide end-to-end visibility around how healthcare is being delivered and by who and for how much, and what kind of quality outcome is being realized through those financings.
Excuse me, may I have a short comment? So the pandemic has shown us that, as he just expressed in the example, from one side, there are they spent $10,000 per year in USA, but now in pandemia, they have more problems. There are more debt, and the healthcare system just broke up. So after this pandemia, I'm sure that all the healthcare sector has to be reestablished, and financing, hospitals, privatization, and so on. All those changes have to be reviewed.
Microfinance. That was
Yes.
that was my question. That I was
Absolutely.
okay trying to put to Jyoti.
What I wanted to add before I asked Dr. Green, who just joined us, to talk about the government perspective, in terms of diaspora care. So you're focusing on the payments from, let's say, diaspora to the region, but here we find ourselves now in a situation where many of the people here may be out of work. So are you contemplating in any way some kind of a micro insurance scheme so that hopefully we can create a new form of insurance? I know the insurance system is broken here anyway, but given that we can rethink insurance, so it doesn't have to be insurance of the past, but can we come up with a new form of insurance or microinsurance that if people are out of work here, they can still be providing or supporting health care for their loved ones? Have you given any thought to that being maybe the next stage of your healthcare financing model?
Absolutely, Dr. Claire. In fact, microinsurance that is enabled through micropayments. Now, those of us who grew up in the continent, and I grew up actually in an environment where I saw every day how a pharmacy runs, a family friend pharmacy, a lot of times how we break up pills into half and sell it for a specific amount of the local currency, right? Mm-hmm. And really, we have to meet the needs of the customers where they are. And this is where microfinancing or micropayment comes into play, where instead of requiring the very expensive payment process to deliver maybe sometimes a very basic healthcare service, how do we enable the local concierge doctor or the nurse or a specialist, a dermatologist, to be able to do what they do, what they're good at, but still get paid in a micro payment ecosystem? And then think about the number of individuals who are unbanked and who are still needing either those healthcare services or deliver healthcare services. So our view is very broad in terms of how we want to address these issues, but we're also taking a very intentional crawl, walk, and run approach, because this is a complex model to overcome. And this is where we see ourselves really bringing some innovation into the ecosystem over the next couple of years.
So we've been joined by Howard Anglin. Howard is a blockchain specialist, and he was in Rwanda last year. Howard, could you jump right in and tell us how blockchain might help on the financing / payments or insurance schemes in terms of providing care? You have the
Can you also explain some to viewers what blockchain is also?
Of course. That's quite a tall order, but I'll jump right into it. And thanks for inviting me. Thanks for having me, and apologize for being late, having some technical difficulties earlier. But besides that, so I was in Rwanda it was February of this year, actually, earlier in February. And in Rwanda, they're doing quite a few things from a technology perspective as well as on the financial side, and basically setting the example for the rest of the continent. So on blockchain, so let me try to give a very general description of what blockchain is. So blockchain is essentially a distributed recording system for storing transaction records. So when I say distributed, that means there isn't a central database, if you want to call it that. The data is stored on different nodes in various locales, various locations. So there isn't one version of that data. So blockchain relies on there's some things happening to my screen.
Don't get too complicated. Just jump into what it can do.
Yeah. So it's based on cryptographic techniques that essentially allow people to actually interact and share transactions without actually trusting each other. So the trust is built into the system. So you don't have to trust, who you're working with or, who you're sharing data with. You could rest assured that the system will ensure that data is protected and the identity of the folks who are you're interacting with is protected.
Okay.
Now, so focus more now on what it can do in terms of healthcare finance.
So in
healthcare services,
healthcare finance, and unfortunately, I missed out on what you guys were discussing earlier. However, right now there's an escalation in cost and the challenges associated with cost of healthcare for one, and fraud associated with that. So that's one thing. The other thing is payments. How do you pay a provider or a pharmacist? If let's say you travel from one village or from one town or locale to another, and you have to pay for certain goods or services around healthcare, and you don't have a bank account. How will that work out? So blockchain can alleviate that in many respects by some of the, you may have heard of cryptocurrencies. So that's one path that you could take. And if you look at what M-Pesa in Kenya has done with the unbanked by offering financial services on your cellular phone, right? So if that type of capability could be integrated with, let's say, the healthcare system, I think that would actually help to bring healthcare services closer to some of the patients who right now it's inaccessible because, hey, I don't have a bank account and I don't know how to interact with the healthcare system, right? And I don't have the means. You know, obviously having facilities in place like this will alleviate at least one, the lack of a traditional bank account, right? Similar to the M-Pesa, right? So, you know, minutes as a financial engine is one means of doing that. Instead of having an actual bank account, you have a value that's stored on your cell phone that could then be exchanged for health services. So blockchain comes into that again through protecting the patient's data, as well as allowing people or patients and doctors and facilities who may not trust each other to actually interact.
Okay. Thank you.
Excuse me, may I say just a few comments? The current system showed us that there is inequality. The health services are expensive. People cannot easily access. Urbanization, I mean, lifestyle, environment, there are problems. So try to improve insurance system, some financial system, personalization will not improve this inequality and the standard of the health service. I mean, SDG target is for 23, health and wellness for all at every age. So we have to think of a global and of such a system that will be able to cover all the population and everybody. And just to improve the current financial system will not satisfy, I think, that need or that target.
Do you have any insight with regards to artificial intelligence and or what the controversy is around 4G versus 5G? Is that an area where you can speak to?
Of course. I mean, for example, virtual reality, in Israel, they have already started, or with some non-invasive methods, let's say just taking a pill. So even at a distance, you could just diagnose all the gastrointestinal system of the person. So this kind of technology, artificial intelligence and so on, would remove the requirement of the physical presence. So even at home or without coming to the hospital, the diagnosis could be realized. And artificial intelligence for monitoring early diagnosis and, for example, for imaging technology or blood testing, all those kind of analysis could be easily done with artificial intelligence. I mean, with new analysis methods.
Okay. Dr. Nelson, did you have any follow-up?
Yes, so Dr. Green has joined us. Dr. Green is one of the founders or founding architects of the Caribbean Public Health Agency. You heard Dr. Voma talk about corruption and mismanagement of funds. And one of the questions I want to put, so we have here people who are working in the private sector to improve healthcare. As somebody who is focused on Caribbean health and have been for many years, how do you see some of what they're doing in telemedicine and telehealth and diaspora payments in alternative complementary medicine? How do you see the Caribbean governments and public healthcare systems partnering with private sector? I know you also were special envoy from the United Nations for HIV/AIDS, and there was a lot of partnerships for that. How can you leverage what was learned from that process to now this new process going forward?
Yeah. Well, thank you very much. I'm sorry that I'm late, but I did indicate to you we had a previous meeting at the university. I was very intrigued by the interventions that I've heard, and especially the techniques involving the blockchain, as well as the last intervention, which spoke about artificial intelligence and virtual reality. But let me be a little more specific to the issue that you raised and the kinds of cooperation, the kinds of lessons that we could learn in the Caribbean, but also the kinds of innovations that have arisen as we moved along, learning the lessons from HIV/AIDS and other things in the Caribbean. Now, first of all, I think we need to understand that the Caribbean system, as distinct from what is happening in the larger continental Africa and in Israel that I've listened to just now, they're small countries, and they have indeed developed a formula of working together. I want to say that so that what I'm going to explain about the Caribbean reality came out of quite a few reasoning sessions on how small states could get together to deal with financing of health and the restructuring of health systems. And they established something, the CARICOM region, that's 15 small states, of which the largest is, that you will know about, is Jamaica. But it's smaller than Guyana, which is in South America. But the Jamaica experience is something I'll speak to. And I wanted to say these 15 small states have got together in something called the Caribbean Cooperation in Health. And the Caribbean Cooperation in Health really established the basis on which the small states could collaborate in fighting health diseases, in structuring health systems, and in developing a couple of things that you referred to when you talked about the block grant. One important thing was the establishment of a pharmaceutical procurement system. And it's a system which is operative in one of the smaller islands of St. Lucia. And it coordinates the way that countries in the Caribbean can procure pharmaceuticals at least cost in collaboration with the Pan American Health Organization for effective distribution to the rest of the Caribbean. It is a very important system. But what it means is that if we had a blockchain system, people in the communities could benefit a lot more from this kind of collaboration. Because in effect, what is happening, governments themselves have to pay for the services of the pool procurement. So that's one thing. A second innovation that I think the small countries of the Caribbean has initiated, a second initiative that they have initiated, is what I will call, and it hasn't really worked well, it is the Caribbean insurance scheme. Because in order to be able to have access to health services and pharmaceuticals, somebody has to pay for it. And it was intended that the Caribbean health system would be a leveling playing field for all the Caribbean countries to get involved, so that if you move from one country to another, the same standards of health service and health insurance would apply. Now, this has happened in theory, but not in practice. But it really is a system intended to see how small countries could finance their health systems. And then thirdly, and really I will stop here, we have an experience in the Caribbean, which is based on the HIV response, in which the Caribbean has been relatively, well, highly successful. It has been among the first regions in the world that could say that they're on their way to eliminating mother-to-child transmission in HIV/AIDS. And this is because of the Caribbean Cooperation in Health, of which the Pan-Caribbean Partnership has been a part, and which has ensured that the region works together for financing and for access, okay? And in this respect, the last thing that you need to know about us in the Caribbean, we have just established about 3 years ago, the Caribbean Public Health Agency. And this is an agency which does for the Caribbean what the CDC does for America and what is done for the EU by a comparable coordinating agency. But what is very important for the Caribbean Public Health Agency, in line with what you have been saying, is that it has indeed created a systematic way in which Caribbean countries can finance, can deal with greater universal access to healthcare. But the problem still remains a lack of the safety nets that will reduce the inequities, which I think blockchain is trying to have for Africa. Now, I just wanted to state that as my intervention, having joined the conversation at a later stage.
I want to jump right in here and let people know it's 12:50 and we're going to open the floor to your general questions. But I want to make sure the panelists don't have any question of each other. I have a question to follow up, which is, but is the Caribbean Public Health Agency looking at the private sector or the diaspora? Because we have here on this phone call many diaspora people who are healthcare experts who have solutions. Are we still stuck in the metro that government alone can lead? So, or do you think that this is the time when we can now begin to have institutional arrangements? And the second question is, given the global relationship between the ACP countries, which is Africa, Caribbean, Pacific countries, might we not find a way to strengthen our ability as developing countries now to build out our ability to negotiate better drug prices? Because that came up in an earlier part about how expensive these drugs were. So in the same way that we have a procurement buying system for the Caribbean, cannot the ACP as a bloc now begin to negotiate that on a larger scale? So those are two questions I have.
Okay.
For you.
Yes, thank you. I think what you've said is really very credible, that in fact, there is need for the Caribbean to have better engagements with the private sector. And this has just struck home recently in the response that we have had to the COVID-19. And I just want to make a general comment for the consideration of the other panelists. It's this, that what is happening here in the response in the Caribbean as well as in the UK and in the US is a great degree of government intervention to save the economy as well as to increase access to health. And once this happens, if you look at the historical context, once governments have this entree into solutions, it's very difficult for them to disengage. And what we might be having in future throughout the global system is greater governmental interventions into health rather than increase innovations like the ones that I have heard. I think that it was Jyoti, if that's the way you pronounce your name, refer to, and in fact, the system of artificial intelligence that we refer. So I'm just saying that as a caveat, that we need to be clear that historical circumstances after wars have really increased rather than reduced government's intervention in things like health and social services. But I think that we are at a stage juncture now where it's important for us to broaden the scope of collaboration and to achieve exactly what we achieved when we dealt with AIDS. For those of you, I want you to recall that it was the little islands of the Caribbean that first negotiated with 6 pharmaceutical companies that drove the price down of antiretrovirals from what it was in 2000, $12,000 US per person per treatment. And the negotiations drove the price down by 90% to 1,000 per person in that period. It could happen. And then further on with the generics, the drugs went down to under 100 per year per person. Now, I made that example to show that if we operate in collaboration with ACP and so on, as a wider group, we could make a dent in the way in which pharmaceuticals and other health services are delivered to the Caribbean and Africa and Asia, not as an afterthought, but as a functioning collaborative event that would save the lives of so many people and not create situations that we have inherited, which are now causing havoc and which we are now beginning to see the effects in countries like the Caribbean.
I wanted to add the time, Dr. Nelson. We're 5 minutes over behind. Did we want to open up questions for the people in Zoom now at this point?
Yes, questions from the room. Anybody has a question, you can unlock your mic. And I recognize you when I see your mic opened up. Sally, I am not seeing a Sally on this, okay? Go ahead.
Okay. So I had a question for Dr. Green about big pharma and how maybe the dangerous atmosphere here with the corruption of use of pharmaceuticals.
You have to repeat your question because your voice is breaking up, Sally. Your voice is breaking up. Okay, we're not hearing you. Your voice is breaking up. You need to do something with your mic. Anybody else?
Can you hear me now?
Yes, much better. Go ahead.
Okay, I'm sorry if it's breaking up. So I had a question about how corruptive the big pharmaceutical company here in America is, just because a lot of people are addicted to the medication, and we haven't really done a good job yet of trying to eliminate that problem. And so I was wondering, do you have a perspective on kind of controlling the pharmaceutical companies or the ingestion of just those drugs, that so it wouldn't be a situation like there is in the United States? And it's for Dr. Green.
Oh, well, I believe that big pharmas in the US are really part of this whole agenda of private sector exploitation in situations. And I also believe that because the US has not really tackled its own provision of healthcare in a particular way, that pharmaceuticals are able to almost get away with murder in terms of high prices. I hope then that what is happening with COVID would really reverse that. But your question really is something which is really outside some of the scope of what we are talking, because you were speaking about, I think you were saying addictions, which to me suggested that the access to drugs made available to unsuspecting persons, that there must be some remedy in which you can probably stop the access of persons to avoid addiction. Now, this is a policy that the US is, I suspect, grappling with, but has not necessarily enforced it across the states. And therefore, we would have to hope that that new regimes in the United States, even if it is the same Republican regime would work towards alleviation of this problem that you talk about with big farmers and exploitation of addiction.
If I could jump in here though, I think another way to look at it going forward is if we're moving towards a well-being mantra, right? And we know the OECD has been looking at well-being as a new index as opposed to gross national product because it's not working for us, right? I think we have an opportunity in this quote unquote period of reset for those of us who are have the influence, certainly for Africa and the Caribbean, to rapidly move to the well-being concept where we're not looking at the disease, as Prof said earlier, but we're looking at well-being. So Yaya's company, for example, in telehealth, rather than modeling his approach based on the old, let's say, let's treat a disease format, the system can be set up to treat a wellness approach. So people have can afford to manage their health better because they now have, you know, the ability to test themselves, know beforehand, right? If we have the labs available, if we have the herbs available, we know what bush in what country use for diabetes and hypertension. We now actually have the opportunity, I think, if we have an integrative working group in Africa or in the region to look at really rethinking and remodeling the whole system as a new complex. And of course, to come back to the issue of payments, if we can then have a conversation about how we look at payments going forward, then that also the pharmaceuticals will have to live up to the pledge that they made for the 2030 goals, because the Council of Pharmaceuticals made a pledge that they, the pharmaceutical industry, would do their best to make pharmacy available and affordable and accessible to all. But who is watching? They said it in a piece of paper, but nobody is really, there's no advocacy group, there's no African advocacy group that's really seriously focused on driving it. And perhaps the role of us in the diaspora who have a little bit of extra time. I think Jote at one point had talked about this extra capital we have in time and talent. Some of us probably need to form a health sector task force that can focus on just pharmaceutical access for developing countries from which we come. So we can help to drive the conversation and look at the pledge they made and help them live up to the pledge that they have made.
Yeah.
Thank you very much.
Do we have any more
questions from the floor? Okay, so back to the panelists. Okay. Jote, I think one of the things that I have also some interest in is this idea of going beyond the payments now to the payments from here to how do you use the platform that you are developing and the platform that Yaya is developing. How can we get those two to work together in such a way that we can now improve the treatment process itself? I know right now you are not doing, let's say, treatments because you're talking to somebody's using an app to talk to a doctor. But what if you had a clinic where there was a lab and a testing and a pharmacy? Is this the way forward, you think, based on what you have both been working on?
Yes, absolutely. So what I described earlier, it really is the first phase, what we consider to be the kind of the low-hanging fruit that we wanted to go after and actually bring quantifiable impact and value. Both the diasporans who have the moral social obligation to take care of their loved ones in their home countries, and as well as the local pharmacies, in this case, healthcare providers, opening up new channels to new customer segment, a paying customer segment that they've never had access to before, right? That lives in the US and Canada and Europe. Now, the second phase that we're looking at is how do we help them actually run their pharmacies efficiently with quality, right? So that they can actually deliver those medications, healthcare services with efficiency. We are currently piloting what we call pharmacy in a box, which really literally allows the mom and pop pharmacies to be able to run their pharmacies just like any of the CVS and the Walgreens of the US are running it right now, having a point of sale system, a loyalty program, a medication inventory system, and being able to deploy those solutions at an affordable rate, for those pharmacy owners. The third one, Dr. Claire, that what you alluded to is, what about the clinics and the clinicians? We are actually also pulling together a prototype of what we call clinic in a box. The idea there is really, how do we have visibility to the entire value chain, right? From the person being diagnosed and all the way through treatment and feeling better and going back to being a productive member of society. So we want to connect the physicians with the patients in order to ensure the right diagnosis, which also drives the right prescriptions in the event that a prescription is needed for medications, and ensuring that the right medication is being dispensed at the right price, which is affordable, and ensuring also that those medications are quality. One of the statistics I think most of you may be aware on this panel is that one of the challenges that the continent as a whole is facing today around medication quality is counterfeit medication. In 2019 alone, it's estimated that over 40% of all medication sold in sub-Saharan Africa is counterfeit. So we, diasporans like me, are sending healthcare money back home, thinking that my relatives are getting better, where in reality, actually, either it's not helping, or worse yet, it's killing them. So we have to be able to address those challenges through advocacy and technology. And this is where telemedicine platforms that, like what Yaya is providing, really, nobody can solve this alone. That's a reality. And secondly, the technologies that are needed to address these issues are out there already. It's a question of stitching it together to make it work holistically. And it requires innovative and creative partnerships across the spectrum.
I have a general question. Thank you for that. I have a general question for anyone that wants to answer with regards to training for healthcare professionals, outside of the traditional colleges and universities, with the focus that we need improved quality, we need improved healthcare management systems. Can someone speak to that?
I may.
Yes, Prof.
Yeah. Well, now the internet, webinar, and this kind of thing made it very easy to reach the information, and highly trained and qualified trainers all over the world can come together through internet. So this will be low cost, raise the standard of the people. This is one thing. And then to bring global standards, especially basic standards for diagnosis, for treatment, also for research and development, will lower also the cost of the medicine. And then things like telemedicine or new technologies will also lower the cost of the medical service. At least certain things will be done at home, at distance, without going to the hospital, or less stay in the hospital.
I have a question. Yeah, you already, I know that you had said you are you're involving diaspora doctors, right? And if I'm correct, your company is in 8 countries, like 4 Francophone countries and 4 Anglophone countries, right? Because you're already working with doctors, will you be able to, like Prof said, this training idea and transfer of knowledge, beyond what you're doing with patient care, are you seeing that some of these doctors that are already on your platform could also become trainers of some of the people on the ground in Africa in any way? How are you seeing that?
Okay, Dr. Nelson, thanks for the question. I think, clearly training, education, is direly needed in most of our countries in Africa. And the technologies, the same technologies that are used for telehealth to provide medical care with technology can also be used to provide education, right? So, you know, the internet is ubiquitous, it's everywhere. It's accessible by all. And it's the technologies, the solutions are out there that will enable people to access knowledge wherever they are. Additionally, though, in terms of medical training, I think it's critical, obviously, to have practical training, which is where telemedicine also could play a major role in that, you know, clinicians can actually share real clinical cases with their colleagues or peers across the globe and have second opinion, expert analysis or feedback. And, you know, that's one of the ways in which training of physicians and healthcare workers in general can be accomplished. If you allow me, Dr. Nelson, I wanted to just follow up on what Jyoti said earlier.
Sure.
And also Dr. Green. In fact, you know, I'm going to start with what Dr. Green said. And I think, you know, the governments, you know, obviously have a role to play in really making sure that they transform the existing health systems. And, you know, really have to give props to the Caribbean community for, you know, sort of pioneering that approach. And I think that Africa, although it's larger geographically, can actually learn from that experience, or from that example. But I also think, without dismissing what the governments are doing, that the private sector has a real role to play driving change. So I think we need to start thinking outside the box, right? Because I think the conversations with governments really goes around the conventional ways of doing things, and you know, which in some ways are somehow blocked. And that's where I think the private sector has to really jump in and provide some answers to what needs to be done. In the context of Africa, or maybe let's say our worlds, I think we have a constellation of solutions that need to be brought together. You know, coincidentally, I have been discussing with Jyoti for the past few months about collaborating, right? So, and as Jyoti clearly said, you know, we have to leverage each other's competencies and see how we can collaborate effectively to provide an end-to-end complete, comprehensive solution, right? So what we do here in Africa, we have a telehealth platform by way of an app, which is available to patients everywhere in Africa to access doctors anywhere around the world. What we basically do is remove any notion of borders. So we have patients in 8 countries currently that can talk to doctors in any of the 8 countries, or in the US, France, and Belgium. We have doctors in the US, France, Belgium, Cote d'Ivoire, Cameroon, Nigeria, Ghana, Sierra Leone, Senegal, Mali, you name it, and Cameroon. So what we're doing then is actually bring the best doctors around this platform in each of these countries and make them available to any patient anywhere in Africa, right? Because if you look at each individual country, there is a shortage of doctors. But if you bring the best doctors in each country around this platform and make them available to patients, the notion of the issue of access to care becomes resolved somehow, you know. And we are looking at making it possible for a complete care to be provided, and that's why we're talking to you know, diaspora care, for example, to address the issue of prescription medications and how patients in those countries in Africa can have access to medications after prescription is provided by the doctor online. So, and another item that I need to talk about is payment. In Africa, mobile money is actually king. So we want to make sure that we align with that reality to provide the capability to patients to use their existing you know, channels to make payments, and that's where I believe I think it's Howard was talking about blockchain You know, I'm just curious how we can actually tap into that to provide an additional method for people to make payments. And obviously, the question is whether it's pervasive enough. In Africa today, we have mobile money, but I think that, you know, blockchain will provide an added benefit or bonus to people to be able to actually make payments without being forced to have a bank account. So I think that, in summary, we have a constellation of solutions. We have to just make sure that we can leverage each other's solutions and competencies to make a system that's novel and workable for our society.
I want to jump in here because one of the reasons why what Dr. Vollmer is talking about and what Prof is talking about is important to me is because I think without looking at the issue of labs, because it's all the money you have, you can't diagnose just by a conversation. So between AI and the labs, we have to find a way to make the lab systems more affordable and more sophisticated in Africa. And we have to find a way for the people who are working in the fields, in the universities, on the ground in Africa, trying to get the use of the herbs and the alternative ways of healing. We have to find a way to get those standardized and part of the complex of how we treat. Otherwise, I don't think we're gonna be like building on an assumption that it has to look this way. And
Sure.
so as we think about this idea, perhaps another role for blockchain, Howard, is to, or this idea of trust is for the researchers, let's say, that are working in Turkey on complementary medicine. If Dr. Vollmer was able to put together a network of, let's say, doctors in Africa, all of you on this call already know somebody who's working in this space. So if you had a trial of your 8 countries, right? And you know, say, okay, we already have 8 countries, we have 60 doctors and 100 pharmacists. You actually have a good trial and model with which to actually test out the build out of a whole solution space, right, for this. So another question I have to ask about the financing, we don't have time, but is it possible then that the Diaspora Care platform can be used as a sort of a impact investment platform to gather funds from a diaspora, not just to treat their individual family, but to support somebody like Dr. Vollmer, for example, who is saying, look, I am going to need $50,000, $100,000 to put into place the manufacture of whatever point of contact prototype. Is this something we can begin to look at in this point? Because everybody is getting panicky about vaccines being done in Africa. We all saw the news. So nobody wants vaccines in Africa, right? So what are we coming up with in very short order that the diaspora can not just send what I call stupid Facebook fights, which not going anywhere. The time you spend to spend 5 minutes on a Facebook cursing off each other, why not spend 5 minutes sending us $50 towards providing a solution that would do the test in a way so we know that these people don't need a vaccine in the first place. So is your platform, Jote, able to be pivoted if you had the right input? I don't know who is on this call. Lots of people are on this call. There are 22 people on the call in total. And I don't know who else is on Facebook. But if anybody is listening and you want to follow up, please be sure to send us an email. But can your platform be pivoted? Or can we find the right partners to make sure that your platform is able to collect this kind of impact investment funding to support small pilots along this type of thinking?
Absolutely. In fact, what you just articulated, Dr. Nelson, is right at the core of our strategic intent. And we're starting with what we know, but we also know that these are the type of innovative solutions that we have to be able to implement at speed and at scale, right? And we have to go beyond the kind of the one-off individual investments and really looking at it. Number one, if we have, let's say, state-of-the-art healthcare facility that treats, it specializes in certain kinds of disease states. But we are completely blind when it comes to the supply chain and distribution that's a backbone for it. Well, that could easily render it unusable because we have no idea what kind of quality of healthcare products we bring into the ecosystem. So I think an aggregation of fund through impact investment and those kinds of concepts would enable us to actually take control of the entire value chain, ensuring that not only can we deliver a quality healthcare service, but we have visibility to the source where the medication is coming from, and ensuring the quality of it, and ensuring that it is actually affordable for the population that we intend to serve. So the answer is yes, absolutely.
I know that Jamaica has been doing a lot of work on nutraceuticals. We have doctors in Jamaica who have found that the herbs such as ball moss can be used to treat cancer, right? And they're now beginning clinical trials for nutraceuticals.
Yeah.
Prof, in terms of what's happening in Turkey, have you had any experience, or do you know of people having success in using traditional Turkish herbs and getting funding and support to take them into the nutraceutical phase and actually have doctors working with these herbs in a new way? And can that sort of information be aggregated out of what I call technical journals, because that's how I found you, from technical journal, but can we take them out of technical journals and put them into real practice? How might we move forward from your point of view?
You're asking to me?
Yes.
It's new. There are certain attempts, but they are not yet sufficient. But I think it will be increased. The scientific papers, research on herbs or methods, because it's more accepted also by the physicians and by the patients. So it's very important that herbal medicine, herbs or remedies are also proved scientifically, like the drugs. And so we should know more about the side effects, or how does it involve in certain diseases or complaints. So we will use them safer.
Yeah.
I was going to ask Cuba, do you cooperate with, because Cuba is an interesting example for healthcare system. And
Ivy Green?
Yes.
Yes, I thought this discussion was quite fascinating, and in particular, the last intervention that you requested, Chair. I wanted to just elaborate that it is correct that we could probably generate effective, low-cost, affordable drugs by greater experimentation with our herbs and our herbal medical trust. For example, in Jamaica, there is the cure for glaucoma, which has now been proven and authorized by the FDA using ganja by 2 Jamaican medical experts. It took a long time for it to be recognized, largely because of a competition with big pharma.
Yeah.
But the thing about it is that you, Dr. Nelson, when I joined the conversation about an hour ago, I think you proposed the way that we, as small countries with overlapping diasporas, could approach it. Maybe your idea of, I would call it a Futures Health and Development Task Force, in which it seeks to establish through health information systems that exist, provide a node for a knowledge for health with targets to doctors, to healthcare workers, and in some cases, like in Haiti, to midwives that in Haiti perform the functions of deliveries much more than in hospitals because of ancient traditions. And maybe it happens also in some parts of Africa. And another nodal point would be community health workers. So in fact, what the task force would do would be to establish a link in which knowledge for health really is something that disseminates, granulates, so to speak, those heavy findings from journals into practical, operational advocacy for groups and for people using the mechanism of health information systems that are common across the network that we are targeting. And so I think that this might be one of the ways that we can move ahead in future to institutionalize discussions like these that we are having into practical realities that transform us into thinking more about payment, mobile money systems, increasing laboratory collaboration, and so on. And I don't want to go further because hopefully by now you get my idea that I am supporting a mechanism that brings us together, Africa, Caribbean, Asia, Turkey, into this particular Health Futures, Health and Development Task Force.
Well,
No, any questions from the floor before we wrap up? It's 1:25. We're drawing to a close. No, Mark, any suggestions from the
I wanted to add another perspective to the blockchain discussion. I know that it was heavily pointing toward a financial solution, but there are several solutions that a blockchain framework can help to not only alleviate but make a better. For example, enhance telemedicine. I think you mentioned in Asia. So in Southeast Asia, I'm also involved with partners working with research institution, university, to essentially use blockchain technology to also anonymize the data and also make it accessible and available to several parties to research on patient information that has been gathered from the field in order to help create better drug outcomes at a university. So that's another place that a blockchain framework can actually apply. And I believe that it's the gentleman from Turkey. Financial solutions alone will solve the healthcare problem, but I think it has more to do with accessibility, whether it's physical accessibility to health facilities or digital accessibility. So with a digital accessibility, there has to be a digital infrastructure framework in order to collect data, ensure that the data is protected, ensure that patient information is protected, and then AI and other related technology can then be operated on that data. So it's key to protecting that data. And I think it was Yaya who has the several nodes where patient and doctors can come together. That again is a perfect example of a consortium or consortia formed around a blockchain framework to help protect the patient as well as the health providers, the doctors. Where does the data go? Who has access to it and when and for how long? And can a patient then, let's say a patient gets a diagnosis or feedback from a healthcare professional in a different country, where's that data? Can that data be transferred to, let's say, when that patient goes to a local clinic or visits another facility? Will that information or data follow the patient? How can you ensure that? So blockchain also provides that framework to help that to happen. And the lastly is the supply chain. If we're going to conduct our own research based on knowledge that is there, but how do you bring these pockets of knowledge as well as conduct research and share that knowledge within a network so that all can benefit from it? Again, that accessibility and supply chain and fraud also, how do you ensure that that doesn't get inside your network? Then again, blockchain can help with that as well.
Well, Dr. Nelson, we're on.
Right, so it's 1:30 and we have come to a close, a rapid close. I just want to say, closing up, we are at a very crucial time in history. And certainly one of the questions I'm asking myself is what I would want history to say about us in 2030. I'm putting on screen a poll. Would love for some of you guys to take this poll. Let's see how we are doing. There are 3 questions on the poll. Would you be interested in joining a Health Futures working group? What interests would interest you? And finally, would you be interested in joining a roundtable on health in June? In other words, we'll do another roundtable like this sometime in June. So if you could answer the poll, I'd appreciate it. Are you seeing the poll?
Yes,
I am.
Okay. I'm not sure if people online are seeing the polls. So good. All right.
Yes, Dr. Claire, I've seen it.
Okay, excellent. This has been a very exciting conversation. And as we wrap up, I just want to say thank you to our very special panelists. They have been, let me see if I can remember. I can't remember. Let me do it on camera. Starting at my left is Ajote Tadesi. He's from Ethiopia here in the US, an IT person, and he is part of a team working to bring diaspora care to the marketplace. They're in the marketplace in 2 countries. Top right, we have Professor Jengiz Mordenis, who is, and he didn't tell you this part, but in speaking to him, and his interview, in-depth interview, is online at thefuturesforum.org. But he's also a homeopathic practitioner. He also is a cupping therapy practitioner. And one that scared me a lot, he's also a Hiruda therapy practitioner, which is, yes, he uses leeches to heal. We have also joined us Dr. Chasey Voma. She's with founder of a startup called Labs to Doctor Express. Looking forward to working with some of you who may be interested in doing lab testing, lab development in Africa. She's certainly looking for partners in the laboratory space. So if any of you are in the laboratory space as experts, as lab pathologists like herself or other angles of that, please reach out to me and I'll connect you to her. Professor Dr. Ambassador Green, who has so many titles I can't remember, but more importantly, he's an elder statesman in the Caribbean health community. And I certainly wanted to have him on the line because I know if Yaya and Chessie and you people want to get to some of the big wigs in world health, he's the guy I'm going to go to for you. So I am very happy to have him on this call to help move your agenda forward. Yaya Mbawa, who is with the Mbawa Group and is also founder of Zensi, that's the platform. They're in 8 countries in West Africa, 4 Francophone, 4 Anglophone, and I think you're looking for more doctors and more patients. So please, he'll be also sending out more stuff. And again, we really want to get this group going. And finally, but last but not least, we have Howard Angling, who is a blockchain alchemist, as he calls himself. He's the guy that has the patents in this space. And that's why I didn't want to talk too much about it, because he'll be kind of talking above our heads when he starts getting too deep into it. But more importantly, he's very interested in doing work in Africa and Asia. He was in Rwanda this year and certainly is looking forward to, I think it'll be a good fit for some of you here on this call who may not be on the platform speaking, but are also working on providing solutions. So just to run through very quickly, yes, most of you, 89% were interested in forming joining the working group. So you probably can respond to me at the Futures Forum at Gmail, or what I'll do, since you registered, to make it easier, I'll send you all an email that you can respond to, so it's easier for me to get that information. So I'll send that out again. Interests are telehealth education and training is huge. We probably have a lot of people on here who are trainers, health tech apps, drug availability comes up as an issue. locally produced pharmaceuticals, direct paramedical healthcare payments, and micro health insurance. So it's all over the place. And finally, we have most people saying yes, they're interested in a roundtable on healthcare in June. That is 3 months from now. So we'll look at that towards the end of June. And also, some of you are not sure, but certainly, hopefully, you'll spread the word about what we're trying to do. To number one, make sure we don't, expire from stress. One of the best remedies for stress is to ensure that we are really thinking about creating the future we want. So with that said, I want to thank you all again for participating. We have come to the end of a fantastic conversation. I want to thank my guests, most of whom I met for the first time in the last 2 weeks, but I certainly feel connected in a very special way to each and every one of you. And we here at the Futures Forum and Future Sense Now are delighted to have been on this roundtable with you. This is a conversation that I have. I use World Days to drive conversations about our shared future, and we talk about salient ideas for sustainable future. So folks, until next time, as we say in Jamaica, safe journeys and walk good. Take care. Bye-bye.
Thank you, and nice to meet you all.
Yeah.
Thank you.
Thank you for listening to Future Sense Now with Dr. Claire Nelson. Future Sense Now is produced by the Futures Forum in Washington, D.C. For more information, visit www.thefuturesforum.org. Remember, our futures are embedded in the landscape of our present stories. Seize the day, share this story, and share the future.